I'd like to thank for the opportunity to give this presentation today. It's unfortunate that I can't go to Taiwan this time. In Japan, the number of COVID-19 patients is still increasing. When the pandemic is over, I'd like to go to Taiwan again. So today, I'm going to talk about in vivo PET imaging for the diagnosis of Alzheimer's disease. I'll introduce a novel PET tracer for imaging reactive astrogliosis in the brain. First, I'd like to give you some background about Alzheimer's disease. Secondly, I'm going to talk about amyloid PET and tau PET. And finally, I'll introduce a new tracer for imaging astroglia. So as you know, the Alzheimer's disease is the most common cause of dementias. There are about 44 million people worldwide affected by this disease. Development of the disease-modifying drugs currently ongoing. However, there is still no drugs that can stop the progression of this disease. And the definitive diagnosis of Alzheimer's disease is dependent on the postmortem examinations. Neuropathological characteristics of Alzheimer's disease was described by Dr. Alois Alzheimer about 100 years ago, after postmortem examination of the first patient with this disease. The one is cerebral atrophy and neural loss. Second is senile plaques, that is currently known as the aggregates of amyloid beta protein. And the third is neurofibrillary tangles, that is composed of hyperphosphorylated tau protein. Here we show the time course of neuropathology in Alzheimer's disease. Neocortical A-beta accumulation is considered as the earliest pathological changes in Alzheimer's disease. Tau pathology in the entorhinal cortex may start earlier than A-beta pathologies, but this process is considered as age-related changes. The amount of amyloid beta plaques reaches a plateau at the early clinical stages of AD. But neocortical tau pathology progress in MCI and AD stages, and followed by the neurodegenerative process. These underlying pathologic changes can be assessed using biomarkers. The biomarkers of Alzheimer's disease are grouped into amyloid beta, A, tau, T, and neurodegeneration, N, together termed ATN criteria. Amyloid PET is currently the most reliable biomarker of A. Amyloid beta concentration or amyloid beta 42/40 ratio in CSF is also available. And recently, plasma A-beta 42 concentration is also reported to be useful for the diagnosis of AD. Biomarker of tau include tau PET and hyperphosphorylated tau in CSF. And the recent studies have also shown that the plasma phospho-tau is also useful for early diagnosis of AD. And that correlate well with tau PET data. And for neurodegeneration, we usually use MRI and FDG PET. And recently, plasma neurofilament light chain, NFL, has been reported to be useful as a biomarker of neurodegeneration. The ATN classification is not intended for routine clinical practice. However, it will help to understand the underlying pathological changes in each patient. If your patient have memory impairment and both A and T biomarkers are positive, their clinical symptoms are caused by AD pathology. And if patient was amyloid negative, but neurodegeneration positive, they are classified as suspected non-amyloid pathology called SNAP. This is a heterogeneous group, including primary age-related tauopathies and limbic predominant age-related TDP-43 encephalopathies. And if patient was amyloid negative but tau positive, they are suspected to be non-AD tauopathies or primary age-related tauopathy. So first of all, I'm going to talk about amyloid PET imaging. For amyloid PET imaging, we use beta sheet binding ligands that is largely labeled with C11 or F18s. Amyloid PET is potentially useful for early detection of AD-related pathology and differential diagnosis of dementia, prediction of prognosis, and understanding disease mechanism by longitudinal assessment of tracer uptake. And in the clinical trials of anti-tau drugs, these imaging techniques are useful in subject enrollment and drug efficacy evaluation. Amyloid PET has been available for over 15 years. As you know, the PEEP, C11 labeled PEEP, has been widely used as a gold standard of amyloid PET tracers. In addition to C11 PEEP, several fluorine 18 labeled tracers are also available. The overall quality of PET image is similar in all these tracers, although the F18 level tracers tend to show slower kinetics and greater binding to subcortical white matter than C11 labeled PEEP. We can use amyloid PET as a biomarker of A-beta depositions because autopsy studies were performed in patients who had undergone amyloid PET. There is a strong correlation between in vivo PET ligand retention and histopathological measures of A-beta pathologies. High cortical tracer retention indicates high amyloid burden. And the spatial pattern of cortical tracer retention is consistent with neuropathological distribution of amyloid plaques. As observed by many researchers, more than half of patients with amnestic MCI show amyloid burden in the brain. And amyloid positive cases are more likely to convert to AD dementia than amyloid negative MCI. In contrast, non-amnestic MCI subjects tend to show negative amyloid PET scans. Thus, amyloid PET is helpful for risk assessment of disease progression in MCI. Amyloid PET has been applied to a wide spectrum of neurodegenerative conditions consistent with the finding in neuropathological studies. Majority of patients with posterior cortical atrophy and logopenic aphasia show positive finding in amyloid PET. In contrast, amyloid PET is not frequent. Amyloid deposition is not frequent in patients with behavioral variant frontotemporal dementia, semantic dementia, and progressive non-fluent aphasia. And amyloid PET is not useful in the differential diagnosis of DLB with AD because more than half of DLB patients also show the amyloid deposition. So when we examine all the patients, we should be aware of the possibility of asymptomatic amyloid beta deposition in all disease conditions. The prevalence of amyloid PET positivity in older people is similar to the prevalence of amyloid depositions as established by neuropathologists. Amyloid PET is positive in 37% for the age group of 70s and 50% for the age group of 80s. And amyloid PET positivity parallels the prevalence of dementia in general populations, predating it by 10 or 20 years. And longitudinal PET studies have clarified the natural history of A-beta deposition in sporadic AD patients. It was estimated to take 12 years from the normal level to the threshold of amyloid PET positivity, and it then take another 20 years to go to the average level of amyloid deposition in established AD patients. As disease progress, the rate of A-beta deposition starts to slow, trending toward the plateau. And amyloid positivity is strongly associated with the prognosis in elderly people. The risk of cognitive decline is about 3 times higher in amyloid positive healthy control than amyloid negative controls. And as shown in previous slide, amyloid positivity in MCI is a very strong risk factor for future cognitive decline. And amyloid PET has been widely used in the clinical trials of anti-A-beta therapy. So as you can see, the A-beta antibody aducanumab demonstrated dose-dependent reduction of amyloid plaques after the treatment. So the amyloid PET can facilitate appropriate patient selection and measure the effectiveness of A-beta clearance. So this is a short summary of amyloid PET imaging. Amyloid PET can be used as validated biomarkers of A-beta burden and offers useful information regarding the progression of MCI. Amyloid PET is helpful in the differential diagnosis of behavioral variant FTD and AD, and can detect A-beta depositions in cognitive normal individuals who are at increasing risk for cognitive decline. And amyloid PET is useful in the evaluation of drug efficacy and subject selection in the clinical trial of anti-A-beta drugs. So the next, we will move on to the tau PET imaging. As I presented in previous slide, the time course of tau deposition is different from A-beta deposition. Amyloid plaques appears abundantly in the neocortex of preclinical AD patients. In contrast, neocortical tangles rarely observed in cognitive normal individuals. The density of amyloid plaques reaches a plateau at the early clinical stages of AD. However, the neocortical tau pathology progress after clinical symptom appears. Therefore, the tau PET is considered to be more useful for tracking disease progression and for assessing disease severity after dementia symptom appears. This slide shows the chemical structures of the first generation tau PET tracers. For tau spear, also known as AB4051, was originally developed by the Siemens, and now this tracer has been widely used for clinical research. This slide shows the for tau spear PET images. You can see tracer accumulation in the temporal and the parietal cortex of AD patient, AD dementia patient, and the amount of tracer accumulation increase with increasing severity of dementia. And when subjects were divided into amyloid negative and amyloid positive groups, sorry, neocortical tracer retention is observed only in amyloid positive MCI and AD patients. Amyloid negative cases exhibit no remarkable tracer retention in the neocortex. This finding strongly suggests that the amyloid deposition in the neocortex could be a trigger for the spread of tau protein from medial temporal cortex to the neocortical areas. The first generation tau tracers have several drawbacks, including the off-target binding, slower kinetics, and insufficient binding affinity to tau. Therefore, the new generation tau tracers have been developed to improve the binding and the pharmacokinetic properties of radio tracers. Among these tracers, MK6240 is currently considered as the best tracers for imaging PHF tau in the brain. This tracer clearly differentiate AD patients from controls and show little off-target binding in the basal ganglia, midbrain, and choroid plexus. For tau spear, the first generation tau tracer is reported not sensitive to early tau pathologies. In contrast, MK6240 is highly sensitive to BRCA1 to 4 early to moderate stages of tau pathology in AD. Because this tracer has a sub-nanomolar binding affinity to PHF tau, higher binding affinity than the other tracers. And we have been developing the tau selective PET tracers, and recently developed a novel tau PET tracer named SNFT1. This tracer is highly sensitive to PHF tau and not bind to amyloid and monoamine oxidase. IC50 value of SNFT1 for tau is 0.8 nanomolar. And competitive binding assay suggests greater binding affinity of SNFT1 for tau than the other currently available tau tracers. And in the autoradiography of postmortem AD brain sections, SNFT1 signals were negative in A minus, T minus, and A plus, T minus brain sections. In contrast, strong tracer signals were detected in A plus, T plus AD brain sections. And this tracer can clearly visualize the spatial distribution of PHF tau in AD hemibrain sections and showed very little off-target binding in the basal ganglia. And this tracer also showed excellent pharmacokinetics in mice brain. So the preclinical data is very promising. So we plan to start the clinical trial of this tracer in the near future. This is a short summary of the tau PET imaging. Tau tracer retention is observed in the common sites of PHF tau in AD brains. And tau tracer retention correlates closely with the clinical severity of dementia. High tau in neocortical region is associated with high neocortical A-beta burden, suggesting that detectable cortical A-beta precedes detectable cortical tau. And novel class of tau tracers has been developed and successfully reduced the off-target binding in the basal ganglia. MK60 to 40 and our new tracer SNFT1 would be highly sensitive to early tau pathology in AD brains that possibly visualize BRCA1 to 2 age-related tau accumulation in the brain. Finally, I will introduce a novel PET tracer for imaging reactive astrogliosis in Alzheimer's brains. Neuroinflammation is an important mechanism in defense response to pathogenic events in the brain. Microglia and astrocytes, two major types of glial cells involved in the regulation of the immune response to pathogenic process in the brain. In this process, several pro-inflammatory mediators such as cytokines, chemokines, and reactive oxygen species produced by these glial cells. And chronic activation of these glial cells play a key role in the development of neurodegenerative disease. A lot of studies have been evaluating microglial activation using TSPO binding ligands. They have shown the microglial activation in the later clinical stages of AD. In contrast, C11 labeled deprenyl PET studies have shown that the increase of monoamine oxidase B positive astrocytes in amyloid positive MCI and also the presymptomatic stages of familial AD cases. It has been proposed that the reactive astrocytes is a very early event in the progression of Alzheimer's disease. Reactive astrogliosis is functional and morphological changes of astrocytes and overexpress intermediate filament such as glial fibrillary acidic protein, GFAP, and also the monoamine oxidase B. In many CNS diseases, astrocytes acquire the reactive phenotypes. The reactive astrogliosis is considered to be a therapeutic target in several neurological disorders. For imaging reactive astrocytes, there are two possible targets, monoamine oxidase B and imidazoline 2 binding sites. Today, I will talk about the PET tracer for imaging monoamine oxidase B. Monoamine oxidase B is mainly located in the outer mitochondrial membrane of astrocytes. And previous studies have shown the age-related increase of monoamine oxidase B density in the brain. But monoamine oxidase B density is also increases in disease conditions such as ischemia, head trauma, epilepsy, and neurodegenerative disorders such as Alzheimer's disease, amyotrophic lateral sclerosis, progressive supranuclear palsy, and multiple system atrophy. The analysis of postmortem brain samples have shown the high density of monoamine oxidase B in the striatum and the hippocampus in control brain. In these areas, there are no difference of monoamine oxidase B density between control and AD brains. However, the monoamine oxidase B density is highly elevated in the neocortical areas of AD brains, especially in the temporal and parietal lobe. As astroglial cells express high levels of monoamine oxidase B, so this enzyme is considered as a good brain imaging marker of astrogliosis. The first radio tracers reported for monoamine oxidase B is C11 labeled deprenyl, and it's a deuterated analog. And fluororasagirin and its deuterated analog have also proposed as the candidates for monoamine oxidase B tracers. However, these tracers irreversible monoamine oxidase B binders. So that makes it difficult to measure the density of this enzyme quantitatively. In our previous study, we observed that the THK5351, this tracer is originally developed as tau PET tracer, but this tracer bound with high affinity to monoamine oxidase B. The binding affinity of THK5351 to monoamine oxidase B was almost a comparable level to the affinity of monoamine oxidase B inhibitor. Although the functional assay showed relatively lower inhibition activity of THK5351. In the imaging pathological correlational analysis, regional THK-5351 binding in antemortem PET images was significantly correlated with the density of monoamine oxidase B and also the GFAP, the marker of reactive astrocytes. That suggests that the THK-5351 PET signal reflect monoamine oxidase B expressing reactive astrogliosis. To develop a selective PET tracer for monoamine oxidase B, we perform the lead compound optimization towards the selective monoamine oxidase B profiles and developed a novel PET tracer named SMBT1. This tracer is highly selective to monoamine oxidase B over other enzymes. This compound shows high binding affinity to monoamine oxidase B and low binding affinity to other enzyme receptors and misfolded proteins such as amyloid beta and tau. This tracer showed reversible binding profile to monoamine oxidase B and AD brain homogenates. And in the autoradiography of human brain sections, SMBT1 binding was greater in AD brain of Alzheimer's disease and progressive supranuclear palsy than the healthy control brains. And SMBT1 signals were completely displaced by monoamine oxidase B inhibitor razabemide, suggesting high selectivity of this tracer to monoamine oxidase B. So we started the clinical PET study using SMBT1 at Austin Health, Melbourne. We examined 10 healthy young controls, 55 healthy elderly controls, including 13 amyloid positive preclinical AD cases, and 12 subjects with MCI and 5 AD patients. These subjects underwent SMBT1 PET, amyloid PET, and tau PET scans. For imaging analysis of SMBT1, we generated SUVR using subcortical white matter as a reference region. Here we have the images of amyloid negative control and amyloid positive AD patients. You can see SMBT1 generate images with high contrast and can differentiate between control brain and AD brain. AD patients showed more cortical retention of the tracers. In control subjects, we can see SMBT1 binding in the brainstem and the basal ganglia that possibly reflect in the monoamine oxidase B in monoaminergic neurons and the normal astrocytes. We compare the non-distribution of monoamine oxidase B in the brain and SMBT1 retention in normal control brains. We actually see that the correlation is very high. SMBT1 SUV follows the rank order from the in vitro binding results. To confirm SMBT1 binding to monoamine oxidase B, we performed the second SMBT1 PET scan after the treatment with 5 mg sertraline twice daily for 5 days. So you can see the massive reduction of SMBT1 signals after the treatment with sertraline, suggesting high selectivity of tracer for MAO-B. And in this AD patient, SMBT1 signal was greater in the right temporal cortex. And this tracer binding overlaps with amyloid beta depositions and also tau depositions. 80 patients showed a significantly higher tracer retention in the broad neocortical areas. And the most important finding in this slide is a comparison of amyloid negative control and amyloid positive preclinical AD cases. Amyloid positive controls showed significantly greater tracer retention in the neocortical areas than the amyloid negative controls. Here we present the SMBT1 PET images in amyloid negative, tau negative control, amyloid positive, tau negative preclinical AD, and amyloid positive, tau positive AD dementias. So you can see greater tracer signals in the neocortex of amyloid positive, tau negative control than amyloid both amyloid and tau negative control cases. In the SPM analysis, amyloid positive controls showed greater neocortical retention than amyloid negative controls. And in AD dementia patients, SMBT1 retention tends to be more extensive than preclinical AD cases. In this patient, you can see the overlap between the areas of SMBT1 retention and amyloid deposition. And we see the correlation between the amount of SMBT1, amyloid, and tau. Considering the all group together, we observed a much higher correlation of SMBT1 with amyloid than tau. And interestingly, the posterior cortical areas was more correlated with than the frontal areas. And we also examined the correlation of cognition with age, gender, A-beta, tau, and SMBT1 retention. Only tau is correlated with cognition, and SMBT1 retention is not directly associated with cognitive performance. So this is a summary of the SMBT1 PET studies. SMBT1 show high binding affinity for MAOB, and the spatial pattern of tracer binding was consistent with MAOB density in the autoradiography of postmortem brains. This tracer yielded high contrast images at 60 to 80 minutes post-injection, and tracer binding was completely displaced by after the treatment with sertraline. SMBT1 binding, when compared to amyloid negative, tau negative old controls, was significantly higher in cortical regions of amyloid positive, tau positive AD patients, and also the amyloid positive, tau negative preclinical AD patient. And when all groups considered together, SMBT1 is highly correlated with A-beta, slightly less with tau, but is not associated with cognitive performance. From these results, we concluded that SMBT1 is highly selective MAOB tracers and can be used as a surrogate marker for in vivo assessment of reactive astrogliosis in the clinical studies. That's all. So I'd like to thank all the collaborators in this study. So thank you very much for your attention.